Welcome to today's ECG webinar presentation titled Healthcare Acquisitions, the Key to Integrated Clinical Care in a Value-Based Environment. This is the first in a three-part series focused on healthcare transactions. The most effective organizations are proactively assessing their clinical capabilities and acquiring programs, services, and infrastructure to quickly fill existing holes. This webinar will help you understand how to properly examine your current continuum of services and ultimately develop a strategy to assemble the best infrastructure and institutional competencies to successfully drive regional integration. Hi, I'm Sean Hartzell, and I'm a Senior Manager with ECG. I'm pleased to be your host for today's webinar. Before we introduce today's speakers, let's go through a few details about the webinar. It's 60 minutes in length. The first 50 minutes of the program is a presentation followed by a 10-minute question and answer session. Everyone should have received a copy of the session handouts, but if you are a late registrant, you can download the handout in the handout pane on your screen. In addition, we have other documents for your review at your leisure in the handout pane. Note that attendees are participating in listen-only mode, but if you have questions, you can type them in the question and answer pane located in the toolbar on the right of your screen at any time. At the end of the formal presentation, our speakers will answer as many of your questions as possible. Finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is important to us, so please take a minute or two to complete this survey. For each survey completed, ECG will make a $5 donation to Doctors Without Borders. Now let's meet our speakers. Our first speaker is Matt Sturm. Matt is a Senior Manager with ECG and co-leader of our Transaction Advisory Services and Oncology practices. His career is focused on working with health systems to create improved and enhanced delivery care models. He has deep expertise in strategic and business planning, service line development, and mergers and acquisitions. Welcome, Matt.
Thank you, Sean.
Our next speaker is Laura Henham. Laura is Chief Strategy Officer with Dignity Health Nevada Service Area, where she is responsible for building market share, brand recognition, and profitability. Laura is deeply involved in strategic plan development, oversight and development of integrated delivery system initiatives, and evaluation and planning of growth opportunities. Welcome, Laura.
Thanks, Sean.
So what I'd like to do now is just identify that this is the first of a three-part series in our webinar, and the first being we're going to talk about the key to clinically integrated care in a value-based network. The second part is really focused more on the model, where we're talking about to acquire or not to acquire that physician practice, and that's on February 11th, 2016 at 10 a.m. Pacific time. And finally, we're going to talk about the execution, which is focused on combining forces to manage the continuum of care. And that'll be March 10th, 2016 at 10 a.m. Pacific time. For more information on today's topic, download a copy of the article, Build, Buy, or Align, Creating Clinically Integrated Networks at ecgmc.com. It should also be in your download pane. What I'd like to do now is just briefly touch on what Matt and Laura will be talking about today. What we're going to do today is we're going to explore the evolving landscape for healthcare providers, where the formation of integrated provider delivery networks will be vital to the ability to successfully deliver value-based care. And so we will focus first on talking a little bit more about value-based care, describing payment innovation, then get into network development, and follow that up with the question, should we build, buy, or align? And finally, finish off with several case studies. So with that, what I'd like to do now is turn the presentation over to Matt, who's going to take us through the first part of this presentation. Matt?
Thank you, Sean. So first, we will begin with a brief overview or definition around what we mean by value care. And hopefully this slide 6 here is something that many of you have seen previously, and this is a definition of value being quality of care outcomes divided by cost. In other words, the market is looking for clinical services of equal or greater value or quality that they have received at a lower cost. So as we think about building systems and building for the future, really this is the equation that we need to keep in mind in terms of increasing quality and decreasing cost. At the same time, certainly volume is going to continue to be a critical component of this, whether that's expressed in terms of number of covered lives, initially number of occurrences, et cetera, but patients through the system is also going to be a key component to an organization's success. As we move forward, we're really today in the formation stage. What we're seeing today is a little bit of a chicken and egg syndrome in terms of the dynamics between payment innovation, and that is the movement of payers from fee-for-service arrangements to alternative models, whether those are strictly value-based population health bundled payments or otherwise. And then the development of networks, provider networks, to be able to accommodate and service that type of reimbursement model. And so that's really where we are today, and that's the first two phases are where we're going to spend the majority of our time talking today. But lastly, and I think this is important to make note of, is that once we begin to get those critical building blocks in place in terms of the reimbursement model evolving and the provider networks developing, that the last key component to this then is going to be developing the infrastructure to be able to manage those networks, the ability to have to report and track quality and monitor and so forth, and really building all of the infrastructure that goes around it. That is not going to be a key component of our discussion today. So as we think about payment innovation, really we are on the cusp of the transition today. When you look, so last year, the last really 18 months have been fairly significant in terms of the evolution. So last year, CMS came out with an announcement around their transition from fee-for-service to value-based reimbursement, and specifically identifying that by 2018, their intent is to have 50% of payments tied to what they're calling alternative payment models. 90% of payment linked to quality and efficiency, so that would be another 40% in other arrangements. And then lastly, we have kind of the traditional fee-for-service Medicare. So that's, they're looking that would be only 10% of payments are just truly a fee-for-service arrangement. So from a timing perspective, Medicare has certainly been on a march in this direction, but they are proposing very significant change over the next couple of years. As we look at it, specifically there were a number of initiatives launched last year by CMS. So at the bottom of page 10 here, you see things such as the bundled payments for care improvement. There was the joint replacement bundle that came out. We saw the advent of the oncology care model and other things too, including MACRA and MIPS and so forth. So, it began with kind of this broad picture painted by Medicare saying this is where we're going. And what we're starting to see now is Medicare providing details around what those payment models will look like, how they will reimburse providers. Subsequently, or almost in lockstep, we are also seeing the commercial or the private health plans following step. And so a couple of key things happened over the last 18 months as well on the commercial side. So you see the announcement from Blue Cross around their plans to transition 20% of payments to value-based models. United Healthcare coming out with a similar announcement. This Healthcare Transformation Task Force, which was a larger group, multiple payers involved, articulated a goal of shifting 75% of their business to alternative models, incentivizing quality and reducing cost. And certainly, as you can dive into the details by payer, there have been a number of pilots, initiative projects, et cetera, that have started to evolve over the last couple of years in subspecialty areas. So I think really today the question is no longer, are we moving to a value-based payment model, but more specifically, what will the details of it look like and how quickly will we reach there? I think as well, we are really at a tipping point where here in the next year or two, organizations are going to see a significant amount of their reimbursement tied to these alternative arrangements. Moreover, the pace of change that we saw over the last 18 months really, I believe, is an indicator of what is to come over the next 12 to 24 months in terms of the pace of evolution. So with that, we'll go ahead and kick off our first polling question. And the question is, when do you anticipate that your market will reach critical mass with fee-for-service alternative reimbursement arrangements? Within the next 18 months, within 18 to 36 months, 3 to 5 years, or more than 5 years?
And Matt, this is Sean. I think I would just want to add, while people are filling out the poll, I think it's really important to note that we have seen that tipping point, I think, as you so rightly identified, in several of these higher cost specialties, orthopedics, oncology, cardiology, and that's really, I think we're seeing that across the country, where some other more commercial payer components are really running more to the primary care role. So I think what I'd like to do, we've had some great responses here, and I'd like to close the poll right now and just let everyone take a look at what the poll is and what some of these implications are. So again, as Matt said, when you anticipate that your market will reach critical mass and with fee-for-service alternative reimbursement arrangements, 51% sometime that said they would see that sometime in the next 18 to 36 months. Then 23% said sometime in the next 3 to 5 years. There's a subset of this, about 16% said they'll see that within the next 18 months, and then there's a few that said it'll take more than 5 years. I guess, Matt, I would just want to throw this over to you to really get what your thoughts are on these results and some of the implications.
So certainly, I think healthcare continues to be very regional. So it's not surprising to see a striation in terms of the relative timing that folks are expecting to see kind of reaching that tipping point. But I think it's very telling that of the audience, 91% of the audience perceives that within a 5-year time horizon that they will reach a critical mass with fee-for-service arrangements. So certainly there's going to be some markets that'll be a bit slower, but I think that's very telling in terms of where the industry is at and what people are thinking in terms of being prepared and being proactive today to move in that direction.
Yeah, Matt, I would say I agree with you on it is a when, not an if. And so what I think we'd like to do now is let's jump into the next part of the presentation. Matt, I'll turn it back over to you to talk about section 3 of the presentation.
Perfect. Thank you, Sean. So we have concurrence, if you will, from the group that we are on a fairly short time horizon to a new world, if you will, in terms of value-based reimbursement. So the operative question is, what does your clinical care model need to look like in order to effectively provide services in that arrangement? So as we think about it, really, kind of breaking it down, there's substantively three key components to this from your physician aspect, and certainly as well there's your facility, your hospital and other component as well that dovetails with this. But as we think about the services organized into primary care specialists and subspecialists, really it's going to be a matter of having a comprehensive set of services that are able to get patients into the network and keep patients within the network. So first is going to be as you go to market, whether you are competing or marketing directly to patients, to health plans, to employers, et cetera, a critical component is going to be the ability to demonstrate that the network that you're offering and have assembled is comprehensive in nature, such that once patients are in, that you're able to provide the continuum of services that are needed. Next is the ability to manage the cost of care, right? So once you have the patients, they're in your system, if you are in a value-based model, population health, bundled payment, et cetera, you now have risk in terms of the care that is being provided to those patients. And so as you assemble the network, it's going to be critical that not only are you diligent in terms of the providers that are added to it, but as well as developing care pathways and protocols and ensuring compliance with those, such that the cost of care is in line with how you have contracted to provide care for patients. Then lastly is maintaining patients within the network. And so that's both having the services as well as being able to have the connectivity within the network. So again, this slide 14 here just breaks it down into a little more detail. So again, the patient referral capture piece is going to be about having the breadth of services. And I think when we think about referral capture, it's not only getting patients started in your network, if you will, but also at each touch point, keeping them in the network. Again, it is about both being able to get the revenue, keep the revenue associated with that patient, but also, and perhaps more importantly, ensuring the services and the providers providing services are doing so in a cost-effective manner. Again, the patient retention, keeping the patients in your network aligned with the high-quality providers, and then the cost management component. I think certainly a key component to that is going to be the ability to track and monitor how care is provided, whether pathways and protocols, et cetera, are followed, and how your physicians are compliant with that. So the question then becomes, where do we start? I would imagine, while there certainly are some more progressive organizations out there today that have fairly comprehensive services, many of the clients that we work with still have numerous gaps. And so as we approach this question, I think first off, there's two ways to look at the question. One is you can, if you will, boil the ocean and look at end-to-end clinical care within your organization. Alternatively, you can break it down by service line or specialty area. And this is where we see many organizations focusing today. So for instance, you might look at your cardiac program or your oncology program, and what are the mix of services and so forth that you have within that program to be able to provide this network of care. So first, really the first question to ask or to assess is, what are the services necessary to round out the clinical portfolio and enable you to compete in a value-based environment? In other words, what are you missing? And specifically, again, I think the lens that needs to be applied as we look at this is, from a cost perspective, where is the risk in terms of patients receiving higher cost care? Next, how do we prioritize the needs in terms of adding services, adding providers, et cetera? Looking at the priority of those. Again, I believe the cost aspect is a critical component to that, as well as when you go back to that diagram in terms of the cycle and the retention of patients, keeping patients in the network. Making sure that those key holes where if patients leak out for, say we're talking about your CV service line and cardiothoracic surgery, if patients leave at that point, there may be a real risk that they don't come back in for their continuum of services thereafter. As well, there's a real risk in terms of how costly that service may be. Then lastly is, what is the strategy to fill those holes in terms of how do you go about acquiring providers to provide those necessary services? So and that's what we'll spend the last section of today talking about, is really that strategy component. So next, I think this diagram here is intended to provide a generic roadmap, if you will, for organizations in terms of what we believe. So again, our perspective is much in line with the response from the audience, that somewhere in a 3 to 7 year time horizon, we believe most markets are going to see critical mass in terms of value-based reimbursement. So lining that up with what is critically important on an evolutionary perspective, what we see today is organizations need to be focused on really kind of four key areas. It's the basic blocking and tackling around your acute services, subspecialty, especially subspecialty providers for key programs. So again, going back to Sean's comments around the high-cost clinical service areas, oncology, cardiology, orthopedics, perhaps neurosciences. The primary care, developing a robust primary care network to get patients into the program, and then developing robust clinical programs around particularly these high-cost areas. Over time, then as once you've reached that tipping point, and as the market continues to evolve, developing more sophisticated and more comprehensive programs is going to be important. So that's where we'll see more end-to-end ambulatory care, the advent and expansion of retail clinics. Again, looking at alternative models to deliver quality care as cost-effectively as possible. As well, bringing in specialty providers to support population needs as necessary. So again, further expansion of your clinical services. And then lastly is really going upstream, if you will, in terms of wellness services, chronic health management, et cetera, really looking more specifically around population health. So with that, we'll go ahead and turn it over to our next polling question.
And so, Matt, what I'd like to do right now is just read that polling question for everyone. In what clinical areas does your organization have strategic gaps that it plans to fill over the next 3 years? Please select all that apply. Acute services, e.g. additional locations, primary care, high-cost specialties, other subspecialty providers, or retail medicine. Please vote, and we will move forward as soon as we get our folks to respond. Thank you. So Matt, yeah, I think it's important as we think about the network development. It's critical to understand when we use that. Now we have this new nomenclature around narrow networks, ACOs, bundles, episodes of care, and really that whole patient retention is critical to be able to really focus in and achieve the results we want from all of those words that are now in our vernacular. So I think it's critical to really not just understand where we're going, but what those terms are. What I'd like to do actually now, we've had some great responses, and I'd like to close the poll and let everyone see the results. And so again, moving back to what the question was, what are those clinical areas that your organization has strategic gaps and it plans to fill over the next 3 years? Primary care, 57%. Retail medicine, 45%. High-cost specialties, 33%. Acute services and other subspecialties are both in the 20s. Matt, how does this jive with what you're seeing out in the market right now?
Well, I certainly this lines up closely, right? So we're seeing a lot of focus on primary care and the retail medicine aspect. Certainly continued focus around high-cost specialties. I think the thing that's most interesting to me in looking at this is the level of interest in acute services. So looking at a more robust geographic platform in terms of additional locations for hospitals and so forth. So that is interesting.
Yeah, I agree. Well, Matt, why don't you take us away on the next few sections, and we'll just jump back into it.
Perfect. So as we think about key considerations in terms of prioritizing your network development areas, key things to keep in mind are going to include the financial impact that a specialty or a program is going to have on the organization. Again, keeping in mind here that we're looking at this from both a revenue perspective, near-term opportunity, as well as a combination of volume and cost, if you will, going forward. So that the financial aspect is a multifaceted analysis that needs to go into that. Next is the strategic importance in terms of building programs, attracting patients both from a fee-for-service world, right, of getting patients into your orthopedic program today, but also then building to the future of having a network that you're able to go to market and market that as a part of your continuum of care and is attractive to patients and to employers. As well, the organization of services. So as we start to think about how we're going to fill these needs, how are the services provided today in the market? Is it organized? Is it consolidated, fragmented? Are providers aligned with your system or another system? What is the current state of that service? Along with that, what is the relative performance or relative strength of the providers? In other words, are these your A team of physicians and clinicians in the community? At the same time, then looking at trends around acceleration from health plans to financial risk for the particular area. So again, if we're thinking about orthopedics or oncology, what are the tea leaves saying from the health plans around their efforts to move risk into that particular area? And that's going to inform the relative timing and prioritization of making efforts in that area. Then lastly, certainly all of this, the strategy is good and so forth, but as they say, culture eats strategy for lunch. And we know that there's going to be numerous other considerations in terms of stakeholders both within and outside of the organization that shape and influence the strategic direction that the organization takes to fill and round out the network. So finally, as we think about network development, I think the last key piece for us is timing. So, again, going back, we said, looking at our tea leaves, we said somewhere on the 3 to 7 year time horizon for critical mass around value-based payments. We heard from you all that the majority are thinking more in the 18 months to 5 year time horizon. So regardless, if you say somewhere in that 3 to 5 year windows, what we're looking at or working towards, it takes time. It takes time to build or to acquire these competencies. So organizations need to be thinking about it today. So key things that are going to shape and influence the specifics around your strategy are looking at this from both a payer and provider perspective around what is the level of consolidation in the market today. So the more consolidation that we see in markets, either from health plans or from providers, is going to be beneficial or help expedite, if you will, the transition to value-based reimbursement, because there's greater critical mass. There's less parties that individuals are having to work with. Next is the willingness of organizations to participate in alternative models. We've seen some markets where payers and providers are willing to move quickly to do that, and other markets are more reluctant. And then lastly, the level of clinical integration that exists today in the market? Certainly, how far down the line are you? So I will close out my portion. Last section here is really around what is the strategy to buy, build, or align to fill out the networks? What is the optimal strategy to provide these missing services? Oh, sorry. So first, when we think about it, the build strategy really is just that. It's developing a new clinical service. It is oftentimes bringing new providers to the community, typically done when either the existing providers are inadequate, meaning you don't have clinicians, the necessary clinicians in the market, or they're unwilling or uninterested to align and consolidate with the health system. Next strategy is the buy strategy. So again, oftentimes this is going to be the most expeditious approach, whereas the build is typically your slowest approach to developing a clinical program. The acquisition, like I said, is typically fairly efficient, and it works well when there are existing resources that are high performing and effective in the community. The advantage certainly there is you bring an established client base, or you bring a referral network in terms of growing the business. The alignment model really is an alternative, typically used when organizations might like to buy or acquire or assimilate, but for various reasons, whether that being regulatory, right? So if you're in Texas or California, a full acquisition employment model, if you will, for physicians is not viable, so there's alternative arrangements. Or you may have situations where the providers, the physicians, are not yet ready to move into that arrangement. And so what we see is a range of alternative models that can be used, ranging from, at the left end of the arrow here, fairly loose structures that are really meant more so to coordinate care, coordinate services, et cetera, to tighter models that get greater clinical and financial integration. Certainly the further to the right that you move on the spectrum, the better from a value-based reimbursement perspective, insofar as there's more greater alignment of both the economic interests of the entities. So what is the right strategy? It's going to be different in every market. We believe that in today's day, given the timing and the need to move to value-based payments fairly quickly, that in many circumstances the buy approach is going to be preferable for organizations. We have developed, so this tool here is a resource to help assess opportunities in terms of what is the preferred approach. And looking at, say, you have a group of primary care physicians, you could ask, what is their reputation in the market? Certainly, if they have poor reputation, that would not be a group you would choose to work with. We go down the line working through these. I think the one thing to note is that it's never going to be perfect, right? You're never going, or very unlikely to have an opportunity that's going to be all signs are going to point to build or all signs point to buy. Likely it's going to be directionally indicative of one scenario or another, but at times there may be one of these particular issues that overrides everything else. Perhaps it's reputation. Perhaps it's willingness of the providers to work with the health system. Perhaps it's a strategic orientation, right? So we have clients right now who have clinicians in the community, but for whatever reason, the organization has decided that it's imperative that they have an integrated program and that the physicians are moderately interested in collaborating. And so they're moving instead in a direction to build their own. So this is going to be very organization specific in terms of how you tailor and how you utilize this tool. But again, I think this can be a useful resource in analyzing opportunities as they come up. And so finally, what I would leave you with is we believe that, as I said, here over the next year or two, that the acquisition model is really going to become the new normal. Given the ability to move quickly, the ability to assemble, particularly in competitive markets where there are multiple health systems competing to develop clinical programs, the ability to move expeditiously and assemble these components is going to be critical. And so that's why we see this really as being a core strategy and a strategic competence that organizations will need to have. So before I move on, I would just offer, I know that we have moved through a lot of material very quickly here, and unfortunately in the webinar fashion don't have the opportunity for more of a dialogue with you all. And so if you are interested, if you find this material of interest or value, certainly myself or others from our team would be willing to sit down and do kind of a one-off or one-on-one presentation with your executive teams if you would like to have a more in-depth conversation around the transition to value and how the buy, build, and align strategies line up with your network development efforts. So feel free to either put a comment in the chat pane or shoot an email to me after the meeting, and we can coordinate to make that happen. And with that, I will turn it over to Laura for the case study.
Great. Thank you, Matt. I'm Laura Henham, again, from the Nevada market, and I wanted to provide just a brief overview on Dignity Health. For those of you who may or may not be familiar with the system, we are made up of 8 distinct markets in California, Arizona, and Nevada. And so I oversee the strategy, strategic planning, business development, mergers and acquisitions, growth of our integrated delivery network throughout Nevada. Primarily our holdings are currently in the Las Vegas Valley and the greater Las Vegas area. It was important from my perspective to talk about the mission, vision, and values of Dignity Health. Oftentimes we talk about them, we feel good about them, and from where I sit, these components of our organization and the values in particular just become more important all the time. One of the things that we do when we are assessing a growth opportunity, whether it falls within the build, buy, or align, and I like the way that Matt put that, we participate in what we call a values discernment. And it includes the potential collaborator, partner, other organization, other individual, whether it be a physician practice, or another entity, another healthcare entity. We think it is critically important that those values align. And as we've moved through a number of growth opportunities in this market in the recent past, it's become very clear that having that values alignment is good business. And it becomes abundantly clear when we have values misalignment, and I'm sure everyone on this webinar has experienced that in some form or another. And so it's something that I really like to put up front. It's one of the things that we've made a concerted effort to talk about with potential physician partners as well as other joint venture partners. As far as an introduction to our market, on slide 28, I just wanted to give an idea of what our market looks like, and again, back to Las Vegas and the presence of Dignity Health in this market. So you're looking at a map of the Las Vegas Valley, and kind of bigger orange icons, if you will, are our 3 acute care hospitals. I thought it was important to also mention we do have an employed physician group. We have the Dignity Health Medical Group of Nevada, primarily made up of primary care physicians, although we have been adding specialists. I also want to acknowledge I spent many years in Southern and Northern California, so I know it's tough to hear about employment, Texas and California and other markets. So you can oftentimes think of our medical group as akin to a foundation if you're in one of those markets. We also have a clinically integrated network of 660 physicians, and we continue to look at different ways, again, to align with physicians. I'm going to revisit the continuum that Matt had shared with you because again, thinking about my specific experience, oftentimes when we sit down with physicians, they go straight to employment. And again, or in a foundation situation, they go straight to, well, I don't know that I want to be part of a foundation. I don't know if I want to be employed. And so keeping that continuum front and center has been invaluable to me, because there's so many places where you could potentially fall along that continuum. And of course, so many of them are not necessarily mutually exclusive in terms of starting at one place, potentially moving further to the right. To talk specifically about our acute care hospitals, on slide 29, we started as a one hospital system back in 1947, and we now have grown to 3 acute care campuses. Our largest is what we refer to as our Siena campus, which we opened in 2000 in Henderson. Our original Rose de Lima campus also is in Henderson, and our San Martin campus is in Las Vegas. I'm going to talk a fair amount about our interaction with employers, health plans, but as we move through our integrated delivery network development, we've found the interaction with employers just becomes more and more important all the time. And I've been impressed by the level of sophistication that many employers have in terms of how they're managing their employee population and at times chronic patients. Moving on to slide 30, for us, we've been about the bricks and mortar, as many health systems have been, and for us it's really much more important to become a healthcare company, a healthcare organization. I'm a big fan of service line development and having that cut across all settings, all landscapes. So in terms of what we're talking about today, creating that value proposition, if you will, we do believe that that makes us much better positioned to deal with what's developing in our market. Las Vegas is still primarily a fee-for-service market. There have been some dominant physician groups that have done an excellent job of accepting fixed payment, entering into risk-based arrangements. For us, that's still developing. Again, touching on markets that I've had experience with in California and in Oregon, and Portland, Oregon in particular, this is a different model. This is a different market from those. And I liked the earlier polling question in terms of asking, how deep do you think that your market will be within a certain time period relative to alternative payment, those innovative payment models. And I would definitely put our market squarely in that 18 to 36-month window. So I like the idea of trying to think ahead. I think once you get to thinking about 5 years, things are changing so exponentially. Certainly in this market, I think it gets tough. But 18 to 36 months, that's absolutely what I see developing as well. On slide 31, you'll see the hill that we're climbing relative to inpatient discharges. This market, we do have for-profit publicly traded companies, number of hospitals owned by Universal Health Services, HCA. UMC is University Medical Center, which is a county-based facility, level 1 trauma center, and then there is one acute care hospital on the market owned by Prime. So you can see that we have had a decline for Dignity Health amongst our 3 facilities in terms of inpatient discharges. To us, what that's telling us is that we need to pay attention clearly, because it's been growing for our competitors. But as we all know, more and more patients, more and more providers want to see their patients on an outpatient basis. The other thing that we acknowledge is the need for convenience. On slide 32 is where we start getting into what do we want to do for our patients. We want to continue to have depth of expertise within each of our acute care hospitals, but we also have to recognize what's important in the ambulatory setting. And so back to the employer discussion, it's critical to understand, especially for the larger self-funded, self-insured employers, we have talked with them directly, and I always am appreciative of the level of detail we can get to relative to a given employee population. And I know that if you were to compare, let's say, Las Vegas to a San Francisco historically, and again, based on information that I've seen, is that many employees like to have primary care that's available to them near their workplace. Oftentimes you can associate that with maybe a little bit longer commutes, different configuration of workers. You've got a lot of white-collar workers, let's say in the financial district, who like that near-site or on-site healthcare access to primary care. When you look at Las Vegas and talk with employers in our market, they're telling us, many of them, not all, but many of them are telling us, don't talk with us about near-site, don't talk with us about on-site. We want you to be where our employees live. And in particular, we want primary care. If we were to go back to the map, and I'm not going to make you go back to the map, but if you were to go back to the map, you would see that historically we've had concentration in a certain part of the market. We're looking for that broader geographic footprint, growing access to that primary care, and again, back to the other polling question, seeing that so many of you on the call are focused on primary care. I also thought it was interesting kind of separating out retail clinics. In my mind, I've already put those two together, the retail clinics with the primary care. I think that they go hand in hand. We've got to find a way that we can be collaborative on that. I've been watching the Walgreens and Providence model very closely. I know there are many other models like that throughout the country. I think that will be a trend that obviously want to continue to watch. And so based on that information, it is critical to understand that maybe don't have as long a commute in a given market. Las Vegas, we've got traffic, but not quite San Francisco or Southern California traffic, and so the on-site, near-site isn't as important. The other thing that employers have told us is they've said, you've got to help us manage our chronic patients. You've got to help us keep our expenses down in these given specialties. And when we get to that level of detail, that helps me connect the dots back to Matt's comments and instruction in terms of how you proceed, how you want to assess, what are the gaps. And for us, the employee feedback has been vital to identifying those gaps. So moving to slide 33, what we've done, based on that cue from employers is we've said, all right, what are the market appropriate, employer appropriate services? How are physicians going to be compensated? So back to the value, providing that high value, is that we had another employer tell us, we historically have incentivized our employees to engage in, healthy habits, encouraging lifestyle changes. And they said, we've realized that they've moved away from it. They've said, we've realized that it's the access to their primary care physician that makes more of a difference from where they sit. And so they said, how can you help us increase that access? There are a number of medical groups that have done an excellent job of providing virtual access. So we've partnered with Doctor on Demand to provide that. There are times where folks are willing to pay cash for that. There are times where employers are willing to pay for that access. And there are times as well that commercial payers, can help pay for that. So those are the kinds of things that we've nailed down in identifying what are the specialty areas that we want to look closely at and again decide on that build, buy, or align. On slide 34, this is where we began to, once we decided on those specialty areas, and I would add that we're continuing to aggressively recruit for primary care within our employed group. So in that case, obviously we want to continue to work with community-based physicians. There's still a fair number of independent primary care physicians in the Las Vegas Valley, but of course I think everyone's had the same experience that those new to practice who are coming out want a more direct employment or W-9 relationship, and we definitely want to provide that alternative to them. But we want to look at, what are the key data points per physician? Back to that geographic reach as far as number of clinics across the valley. How do we want to combine that? Patients, again, are looking for that convenience. Can we provide a one-stop ambulatory shop for them, if you will? And what are the economics? Obviously, we've got to get to some level of return. Primary care can often make that difficult. So what other services can we put with it? Can we afford to offer those services that the employers are looking for and help manage those costs? Because that's the value that we can bring to them. On slide 35, this gets a little bit deeper, again, back to those selected service areas that we've looked at. We have become specialists not only in Plan A, but Plan B and Plan C. We have not been going forward with business plans without a Plan B and a Plan C. That's how quickly our market has been changing. And so we have done, I think, a good job. We always need to refine our ability to anticipate not only the clinical implications and operational implications, but in that financial implications bucket, what's going to be the competitive response? How are referral sources going to respond to a new specialty group in town? What's going to be the response if we consolidate a group or two? Moving to slide 36, this harkens back to the values discussion. So the shared objectives is critically important to us. We want to get to that shared vision. We want to get to those shared values. I think everyone's familiar with, of course you want to have high quality, you want to have efficient operations. Again, you've got to think about the market position relative to your competitors. But in terms of the financial performance, because so much is moving to the outpatient side, we are straddling that middle ground that we're still so dependent on the inpatient performance, but we know that's going to continue to change. So how can our medical group, how can our ambulatory services really stand on their own? And we have to be open also to outside partnerships to help with that financial performance. Moving to slide 7, this kind of highlights one specialty area where we really got down into the nitty-gritty, who's really out there in the marketplace, how many physicians, and it's always an interesting surprise finding out how truly consolidated one area can be while others are largely not. And it is a absolute must on our checklist that we understand how dominant certain groups may be, and we've got to appreciate kind of the corporate memory of a given market so we don't ignore that as we're moving forward with our plans. And then really on the last slide, slide 38, this is that back to the continuum. We're embracing co-management, certainly professional services agreements as well, and for us, we want to make sure that we're always open, we're always flexible, and understanding that for some groups, if we decide to go, let's say, with a buy strategy, or if we're anticipating that there may be a buy strategy later, we've got to have a willingness maybe to engage in a different arrangement, maybe moving further to the right as time goes by, and oftentimes with group succession planning pushes them to a different place. So I know we're pushing on time a little bit. So with that, Sean, I think we're ready to open it up to questions.
Okay, great. Thank you, Laura. And I'm sure that our webinar audience wants to join me in thanking Matt and Laura for the discussion on integrated clinical care. And we'd like to move over to the question and answer portion of the webinar. As a reminder, please continue to enter those questions in the question and answer pane on the right of your screen. And I'll ask as many of these questions as possible as time permits. I think we've got a few minutes left, and what I'd like to do is just open up the floor to some questions, and I've seen a few come in. And so what I'd like to do first, Laura, it's a two-part question for you. The first question is, one, when did your organization recognize the need to develop this integration strategy? And so that's like getting into it. And now that you're into it, is there anything that you would do differently if you could with regard to your approach or your strategy that you're currently embarked upon?
Great questions. I think as far as, when did we start, or when did we start thinking about, an integrated strategy, I have to give full credit to Dignity Health and their corporate leadership. When I came into this position, one of the things I like in terms of the way Dignity Health organizes its markets is that there is a chief strategy officer for every one of Dignity Health's markets. We communicate, we meet on a regular basis, do our best to share best practices, And one of the things that became apparent to me when I started was that integrated delivery networks, that was it. That was the watchword. That's how we frame our discussions. That's how we frame our initiatives. We have regular updates related to integrated delivery network development. And I certainly beg, borrow, and steal from the other markets as much as possible. And obviously, the other nice part of Dignity Health is, although there is the push to share best practices, there also is enough flexibility to say, you know what, Las Vegas is different from Sacramento. Las Vegas is different from other markets within Southern California. So we look for the similarities, but the vision is the same in terms of creating that integrated delivery system. In terms of, if I knew then what I know now, I would probably be a little bit more. I would tighten the pace in terms of, I think there are times where it's okay to pause. It is okay to let an initiative evolve a bit before implementation. Not to say slow it down. There's a lot to say for momentum. Physicians appreciate it. You don't want to waste their time when you're talking about a potential integration opportunity. But by the same token, keeping them involved in the discussion, but not rushing to the answer. And I always say, sometimes the best deals are the deals that we don't do. I would also say that, you're setting a precedent. There are times, believe it, you don't think there's any uncharted territory, and then you discover it. You've got to be thoughtful about the precedent that you are setting. And actually, I would say ECG, and maybe Matt or Sean can help me with this. There's a great article that you guys put together relative to fair market value and how you pay physicians. And then oftentimes physicians will interpret it as an insult if you try to put them at the median, in terms of a baseline compensation related to work RVUs. And so I would highly recommend that article, because it just gives a great perspective in terms of you need to have a well-informed, well-reasoned discussion. Don't push because you think they're going to get snapped up by someone else. Got to value their time, but it's got to be a thoughtful deal that works for all parties, and then works kind of back to that precedent for the larger network.
Yeah, I think that's very true. And what I'd like to do now, actually, we've got a couple of questions that have a lot of similarities. And so I throw this one out, and I'll throw it out to Matt, and then Laura jump in. But there are certain communities where providers are either non-PAR or practice concierge medicine. And really, what's the value for those physicians who aren't willing or really interested in being acquired or employed by a hospital? What are certain things, how do we go about answering that question, the what's in it for me question?
Is the question what's in it for the physicians?
Yes, if they have non-PAR or concierge medicine type practices.
Sure. So yeah. I think, again, it comes back to as a health system, the question is what's in it for the health system. So if the concierge medicine is part of the strategic approach, so maybe as you're developing relationships with employers and having that type of practice as an option, certainly there's then something in it for the organization. Whereas if it's just part of a broader primary care strategy, that may need to be more closely examined in terms of the value to the health system. I think it's an evolution on the provider side of the equation then, right, in terms of how they're looking at the market and the value to them of being a part of a larger health system, the access to contracts, patients, et cetera, as well as the reimbursement models that are evolving. So I think certainly a multifaceted approach in terms of crafting the value equation for both sides in such an opportunity.
No, I think that's very appropriate, Matt. Thank you. So we've got time for one more question. I know we're bumping up against the hour limit, but I did want to get one more question into Laura, and it really deals with what are Dignity Health's thoughts and discussions or partnership opportunities around some of the large casinos, resorts, as it relates to healthcare and say bypassing the insurance companies, really going straight to the employees and employers.
Mm-hmm. Great question. And Las Vegas, because of the, as one might guess, with the hotels, resorts, casinos, it does create a opportunity for working with a disproportionately large share of very large, oftentimes, as I said, self-funded employers. You know, you look at the MGMs and Caesars Entertainment and Sands Corporation. It creates a real opportunity. And as I said, many of those employers are very sophisticated, and we are working with them directly. We actually are contracted with the Health Services Coalition, and the coalition represents a number of employers on the Strip, represents their service employees, culinary workers, and so they've done a good job of banding together, if you will, and going out and contracting directly with hospitals, at least on the inpatient side. And so through the coalition, we've had the opportunity to address, what is it that those employees and those employers really want. There are a few large casino resorts who are not members of the coalition, and we've been in touch with them directly. And as I said, many of them are looking for a solution that addresses where their employees live. So I think for us, we've got to continue to refine our approach, and as I said, we've got to find ways, what is it that their employees need? What's worked in the past? What's failed in the past? And so they want to make sure that they're providing value in turn to their employees. And, so much is changing. Many of the employees, depending on, of course, how they've crafted the benefits, of course, there are higher and higher deductibles, higher and higher out-of-pockets that effectively makes those patients, those employees, cash payers, cash buyers. And so that's why I like to talk about retail clinics, because in so many respects, they're retail buyers. Whether they really are or not, whether they're fully insured or not, they are retail buyers. And we've got to find ways to address them as retail buyers, and that's different for us. So I think anything that can plug into their wellness programs, and again, going to where they want it, not pulling them to us. We've got to go to them.
Right. Yes, thank you. Thank you for that answer. For the folks who have submitted questions that we haven't had a chance to answer in the webinar, our presenters will be sending you back answers to those questions in the very near future. With that, this concludes today's webinar. Please take a moment to complete the electronic survey upon exiting today's session. As stated earlier, for each completed survey, a $5 donation will be made by ECG to Doctors Without Borders. We hope you will join us for other ECG webinars. Visit trends.ecgmc.com for more details or to register for a future session. Check back to the site regularly for more topics as they're posted. Again, thank you for taking the time today. We really appreciate it, and have a great afternoon.